Welcome. My name is Karen Eggleston, and I'm director of the Stanford Asia Health Policy Program. I'm delighted to welcome you today to today's webinar, a joint series between the Asia Health Policy Program and our partners at Peking University on technology and trust. Today, I'm delighted to introduce Dr. Lucy Xiaolu Wang to discuss her important research on procurement institutions and essential drug supply in low and middle income countries in Asia and beyond. Dr. Wang is an assistant professor at the University of Massachusetts Amherst, a faculty research fellow at the Max Planck Institute for Innovation and Competition, Germany, and a faculty associate at the Canadian Center for Health Economics. Her research focuses on the economics of innovation and digitization in healthcare markets, particularly in the biopharmaceutical and digital health space. Dr. Wang earned her PhD in economics from Cornell, her master's degree in economics from Duke, and her bachelor's degree in applied economics from the Central University of Finance and Economics in Beijing. Her research has already garnered interest from international organizations as well as earned international awards, including the prestigious Adam Eightstaff Prize for Outstanding Research in Economics of Healthcare Finance and Delivery in Low and Middle Income Countries, an award also earned by our own Asian Health Policy postdoctoral fellow, Dr. Radhika Jain. So we are delighted to hear from Dr. Wang today about her latest work on essential drug supply and procurement institutions. Please put your questions in the Q&A, and we will get to some of those after Dr. Wang's presentation. Lucy, over to you.
Thank you so much, Karen, for the very kind introduction and for the invitation. I'm very delighted to share my works. This work is very dear to my heart as I grew up in China and have experienced many issues in these areas. As example, as a child, oftentimes I have to travel to another province to find medical care, and then maybe drugs not of the right dosing, so I may have to break drug into half and then do some stuff. So basically, procurement institutions and essential drug supply can be really very relevant to all of us who have root in developing countries. So this joint work with my graduate school friend, Nahim bin Zahu, who is currently assistant professor in Queen's University in Canada. So it's not difficult to tell this audience. There are a lot of institutional failures in access to drugs, and it's particularly severe for low and middle income countries. As we all know, there can be slow diffusion of drugs to developing countries even 10 years, 20 years after they were launched in high-income countries. And there are many barriers in the process. For example, there are weak commercial incentive to invest and sell in low and middle income countries, given that the prices are relatively low. You can't really have similar markup as in high-income countries. There are also supply chain bottlenecks and local production capacity limitations. And we have observed that a lot during COVID, and these are not something one can improve over a very short period of time. Among many other factors, there are also intellectual property rights as being of the height in the discussion, including but not limited to patents, exclusivity, trade secrets. And one thing to keep in mind is that although we oftentimes emphasize the importance of IP for new drug diffusion, but a lot of drugs that are under shortage are actually old drugs that has been off patent for a while. So this is definitely an issue that we have been thought of, but we also want to understand different forces that can change and reduce those barriers to drug access. Among many factors and effort to put into this process, procurement institutions have played a big role in increasing supply of drugs to low and middle income countries. However, we still don't know enough about the efficiency and trade-offs across different types of procurement institutions. But this is very crucial to understand how procurement institutions may contribute to the efficiency of health systems in low and middle-income countries. As we are in the post-COVID world but still have a lot of questions in mind, we really find it's of increasing importance to understand novel procurement delivery institutions. We have heard a lot about COVAX, that's global vaccine alliances that try to pool vaccine demand and supply to low and middle income countries. However, by a very long time, even until now, it's actually China, not COVAX, that has been supplying most of the COVID vaccines to other developing countries. But it's usually not the mRNA vaccine. So as we can already tell, there appear to be some trade-offs. but we want to understand it more systematically. In this paper, we try to zoom in one particular perspectives about decentralized versus pooled procurement institutions. On the left-hand side, we can see in a typical case as in the market force, in a decentralized procurement case, each seller, here it can be an institution within a country or just different country buyers, may need to contact different buyers. And here each buyer can be a different manufacturer. So the sellers will, the sellers and buyers need to communicate and understand, oh, like, do you have this inventory of these drugs? What prices can you give and how much quantity can you provide? So this negotiation between buyers and sellers can be very complicated. So as a result, the prices may not be really friendly if the buyer do not have large bargaining power. It can be particularly challenging for resource-limited countries. In contrast, we can have a pooled procurement institution that aggregate demand from different buyers. So here, different buyers can be either within country, across provinces, like something that's implemented in China as a centralized procurement, but can also be across countries in a larger region. And that is actually a larger focus of this paper. So the intermediary will take role of negotiating with sellers and with the aggregate demand and may be able to negotiate a better deal. But there are also more complicated questions about delivery conditions and delays. So we basically try to understand this pooled procurement institution by focusing on international pooled procurement institution with two particular examples, the pooled procurement mechanism, PPM, and United Nations, UN. I'm going to elaborate more on the distinction of those later. So the overall broad research question is, what are the efficiencies and trade-offs across procurement institutions internationally and domestically for low and middle income country drug supply by first analyzing the effects on multiple key outcomes, including price, delays, and procurement lead times, and also drug choices. And then we also examine the heterogeneity of procurement institutions regarding the age of drugs, which generation of drugs, and market concentration, buyer size, and also patent status. And finally, we also understand the relative merits of procurement institution and intellectual property licensing institutions across drug types. A preview of our main findings. Overall, we find that pooled procurement institutions lower drug prices, especially with international pooled procurement institutions that aggregate demand across countries. And it's particularly so for older generation of drugs where the market is actually pretty segmented. In more concentrated market, when there are a relatively smaller number of sellers that controls large share of the market. And it's also most useful for small buyers with countries of very limited bargaining power. We also look at non-price outcomes, and we find the biggest pooling institution and the pooled procurement mechanism, PPM, also reduces delays, but as a cost of longer procurement lead time. That's the time from when you submit the order to when you actually get the drug. So there appear to be some trade-offs. And we also find the pooled procurement institutions supplement intellectual property licensing institution for drug supply to low and middle income countries. So here we use the word supplement instead of complement because in economic sense, it means something different compared to regular sense. But basically we find this intellectual property licensing institution versus procurement institution are actually most effective for different types of drugs. I'm also going to elaborate that more later. So this paper contributes to two main literature. First, there has been a very large literature about centralized procurement across different industries. And there's also a smaller but growing literature about centralized procurement and drug prices, especially focused on the international setting. And most of these papers focus on one type of procurement institutions and oftentimes look at prices as outcome. And our paper basically tried to provide a systematical empirical analysis of different types of procurement institutions and on some outcome beyond prices, on non-price outcomes. And second, this paper is related to global drug diffusion. And there's a large literature looking at different factors that makes drug launch our drug diffusion faster in different countries. There are market factors, non-market factors. And here we primarily focus on procurement institutions that tackles non-intellectual property barriers and can also supplement IP licensing institutions. So here, whenever I mention about IP licensing institution, it's particularly pointing to an institution that's called Medicines Patent Pool. That is the first ever biomedical patent pool, which is basically a joint licensing alliances that try to engage originating pharmaceuticals to pool their intellectual property rights and know-how together to license out this knowledge as a bundle, as a one-stop shopping. So that is more documented in my 2022 JHE article. So here, one thing to again emphasize is that we have old drugs and new drugs, and many shortages that a lot of countries face actually for old drugs, not only for new drugs, because the markup can be relatively low and the profits margin are not really high. So we try to dive deeper into that later. So when we talk about institutions or procurement institutions, how should we think about them conceptually? There's been literature, both theoretically and empirically, ambiguous about the price impact of pooling procurements. That is maybe a little bit counterintuitive, because when I started the project, I was thinking, theoretically, it must be lower prices. Although in reality, whether it works really depends on a lot of factors, including the relative bargaining leverage of buyers and also the cost structure. And oftentimes, we can't really know until we get internal cost data. So in reality, whether pooling can reduce prices are not that clear. And the impact on price may also vary by the extent of supply side concentration, buyer size, and characteristics of procured goods. Although in the healthcare sector, we oftentimes find, generally speaking, people agree that if demands are put in a sufficiently well-organized manner, the prices may be lower, although the reality can be a little bit more complicated regarding heterogeneity. On top of that, non-price outcomes on transaction costs, quality, administrative efficiency, and delivery conditions are also very important for global drug diffusion, but those are much harder to study as there's no theoretical guidance about how those non-price impact can be formalized. And empirically speaking, it's also a little bit unclear with relatively limited evidence. So there's another paper by Clark et al., and they basically find there appear to be some trade-offs in terms of medical device in Italian provinces. So one thing that's particularly interesting is that pooled procurement oftentimes use long-term contracts to fix things up front to give you a peaceful mind, but also means that intrinsically there can be a trade-off between more certainty that you're going to get the term you agreed upon, but that also means reduced flexibility. You may not be able to renegotiate the deals over time very flexibly. So overall, it remains an empirical question how pooled procurement institutions affect prices and deliver outcomes. So what is our empirical setting? We focus on low and middle income country procurement of essential drugs for infectious diseases in 4 therapeutic areas, including antiretrovirals, antimalarials, tuberculosis, and antibiotics. Now I'm saying, those feels not that timely, as now we talk about COVID for a very long time. But one thing to keep in mind is that those are still very important diseases that disproportionately affecting low and middle income countries. HIV, AIDS, or tuberculosis and malaria remain the big 3 infectious diseases that collectively kill almost 3 million people per year, mostly in developing countries. And they are estimated to generate larger disease burdens than COVID-19 in many developing countries. And what's also more relevant for future public health institution building is that the infrastructure and investments for the AIDS pandemic have been critical first responders to COVID-19 in many low and middle-income countries. So still further understanding what we did well and what we can improve upon from the last pandemic, from HIV/AIDS, is still very relevant even for nowadays and moving forward. Also, very importantly, we have a wide variety of procurement strategies and institutions. that has been employed that can be used to procure those drugs. So basically, insight from this procurement can still be used for in designing future institutions, particularly by looking at across different countries and in a larger international landscape for a long period of time. So we have been talking about procurement institutions. What are they? So in this paper, we group them into 5 big buckets. So first, the default is the direct from manufacturer in a decentralized fashion, basically from buyer and seller contact each other. And then we also have central medical store and acronym as CMS. Basically, those are within country pooling that pulls order across different provinces or states. In our sample period, there are only 12 countries using them, including South Africa, Senegal, Cameroon, etc. So collectively, they are not that large, but for this country that actually use them, they actually use them for quite some transactions. More importantly, one of our key focus is the Global Funds Pooled Procurement Mechanism, or the PPM. The PPM pool orders across countries, and it's also the institution that takes pooling to the limit. So the PPM not only pool orders or aggregate demand, but also integrate the payment method to simplify the process. In contrast, United Nations also pool orders across countries through an intergovernmental fashion, but sometimes there are more bureaucracy in the process. And beyond so, there are also some others. Basically, there are nonprofit procurement or development organizations, private wholesaler, international health NGOs. Just to have a sense about what are the institutions in our data set, those are different things we aggregated. You can also find some more details in the drafts. And there's also a empirical figure that we constructed to show some differences. Basically, as elaborated before, both PPM and UN first get global fund funding, but then PPM and UN aggregate demand differently. With PPM also have the purchasing order integrated with the financial system integrated into the process. But in general, both PPM and UN aggregate demand across countries, and they both have long-term agreement with manufacturers. The difference is that Global Fund have more direct involvement in the payment process. And then they also need to coordinate different delivery conditions with grantee countries. If it's like aggregating within countries, then the process is slightly different. With the country and grantee takes a more active role upfront and then do this pooling within countries. Okay, so what is the data we are using? This is a very large effort constructing data from different resources. So we have low and middle income country drug procurement from Global Fund from 2007 to 2017, where we have price, quantity, scheduled, and actual delivery dates, and order date, or the purchase order date. We also have the procurement agencies, the manufacturer, and the destination countries. And one thing to note is that we don't have the universe of the data. All the purchases we have are Global Fund funded. So there are pros and cons. The nice part is that all those purchase transactions are relatively comparable in the funding sources. But we also acknowledge that we don't have 100% of the data, which is not something any researchers can legitimately get. So this is probably the best public source one can use for cross-country research. At drug level, we constructed data with detailed information regarding the disease category a drug is treating, the approval year, and here's the first approval year globally by searching extensive medical literature. So we can determine the generation of the drugs and all the different drug classes, not just based on disease they're treating, but also within HIV, there are different mechanisms of action that can be of interest as they need to be bundled for use. We also constructed drug by country by year level patent status and IP licensing institution details. Basically, we combine 3 useful information to have a comprehensive documentation of patent status, including MedSpal and Pet Informed and Drug Patent Watch. So only Drug Patent Watch is private and costs relatively reasonable amount of money, but the MedSpal and Pet Informed are both funded by like WHO, WTO, and Medicines Patent Pool. And then the information regarding licensing status is from the medicines patent pool, which I also have a documented table in my patent pool paper. We also included country year level characteristics regarding demographics, income, disease portfolio within country, institutional features, etc. So here is a descriptive figure about what do we have in our data. As you can see, we have a global map and that covers a lot of countries. So overall, we have 106 low and middle income countries for this 10-year period that have ever used global fund procurement. And we cover 83 distinct drugs, or here each drug we call it maybe a molecule, or let's say you can think about a drug as abacavir or lamivudine. We also have if you look at drug by strength level, let's see, abacavir 100 milligram versus abacavir 300 milligram, we have close to 200 distinct drug product information. So now one question is the sample representative? So during our sample period, if we look at the unique compound that ever approved for treating important diseases, we have 23 out of 29 ever approved HIV drugs. So some of the very newly approved one may not join our sample. And then among all the malaria and tuberculosis drugs in WHO's essential medicine list, we have 13 malaria drugs and all 18 TB drugs. We also have a few extra drugs not listed, so that's the actual ones used by different countries. In general, there are prior documentation by Global Fund saying that the data they provide probably cover about 40% of HIV and AIDS drug purchases by low and middle income countries, although the exact coverage may differ a little bit by year. And more importantly, we observe over 60% of WHO's pre-qualified manufacturers, and that also include all major manufacturers qualified through other important channels. And then if we try to look at what's going on in the sample period regarding who is actively doing procurement during this period, we can see if we look at share of procurement transactions across different procurement institution types, interestingly, we see the most popular modular at the beginning of the sample period is direct purchase from manufacturer in a decentralized manner, but this share has been reducing over time. In contrast, PPM has been rising, although PPM is only started in 2009, but quickly gained momentum and become the most popular modular at the end of our sample period. And there's some other stuff like other institutions, relatively stable. And the central medical store is having some more interesting momentum in the middle of our period. And then UN, the other major pooling institution, basically have relatively stable share over time. One interesting thing I like to just tag here is that the new adopters are increasing over time. If you look at new countries join, there are more momentum throughout our sample period. But if you look at PPM share over time, they're actually relatively stable in the sense that it's not really taking over of everything. All the procurement institutions also capture different parts of the market. And here are some summary statistics. So we have the price information. Later in the regression, we use the log price, so we can basically adjust the data and interpret the result regarding percentage change. As you can tell, the mean and maximum change a lot, although here's pulling everything together. We measure the spending in terms of some dollar here, and we also look at procurement lead time. As you can see, the average procurement lead time is about half a year, but also vary from same-day delivery to almost 3 years. We're also later going to readjust whether they're pre-planned order. And then, as you can tell, about half of them have some sort of delay, and PPM account for about 30% of the transactions when we look at the panel level. So the graph before is at transaction level. One thing that's also be interesting is to look at the patented. In our sample period, about 20% of the drug product by country year observations are patented, about patented drugs in different countries, as patents are jurisdiction specific. And there are about 9% of them were covered by the medicines patent pool. that basically lower the cost to license patented medicine for sale in developing countries. So as you can see, this is probably more valuable for launching new drugs in the country, for patented drugs. So here's our benchmark specification. So in general, we want to think about estimated relationship between procurement institutions utilized and various outcome in a panel regression with saturated fixed effect. So here our outcome of interest are price, delay, and procurement lead time. Our key variable of interest is the share of transactions using procurement institution M. So as you can tell, we have multiple procurement institutions, so we sum them together. So the share will sum up to be 100% with the benchmark as the direct from manufacturer. We also follow literature and include a lot of important observable controls, including income, say GDP per capita, disease prevalence and incidence for HIV, TB, and malaria, different demographics, what governance indicator to capture the control of corruption, rule of law, and different perspectives from the World Bank. We also control for patent status, whether for a given year at a given country a drug is patented, and whether the particular drug in that country in that year is available for licensing with low royalty from the medicine's patent pool. We include very extensive fixed effects at drug by country level and year level to fulfill the two-way fixed effect standard. And we also use two-way clustering of standard error by country and by drug to allow arbitrary autocorrelation of standard errors by country and by drug independently. So we also did additional analysis at the transaction level, and we have also tested other fixed effect level. For example, we did three-way fixed effect to basically saturate all the variation, but in that case, we cannot include observable controls. So I'm going to mostly talk about the benchmark result with the preferred specification, but all the additional analysis are in the draft. And then later I'm going to talk about additional analysis using other empirical strategy, including instrumental variable strategy, Altonji-Elder-Taber-Oster method, etc. So here's the benchmark result. What do we find? If we look at the dependent variable as a percentage of price change as a log price, then the estimate can be viewed as percentage of change. So we basically find that prices are lower with cross-country pooling through the ppm and UN, as a magnitude about 30 to 38% for ppm and 23% for UN. And the difference between column 1 and column B is whether we use two-way fixed effects, the preferred one, parsimonious one in column 1, or with country by product and country by year fixed effect. Then we cannot include these observables. And we also did it at transaction level and with country by buyer fixed effect in a way that we distinguish whether it's a finance ministry doing the procurement or community organization or a health ministry within a country. And here, one difference is that when we use transaction level analysis, each observation is going to be weighted equally. That means a country with many transactions is going to have larger weight in the estimate compared to the previous panel regression, where each country by year by product is weighted equally. So as we can see, the general pattern persists in the way that transaction level prices are lower with cross-country pooling. And as we can see, because now is weighted equally for each transaction, the magnitude is smaller. With ppm lower prices by about 17 to 80%, and UN lower the prices about 10 to 13%. We also find some significant but very small effects of CMS within a country. So that's partly power issue. One question that has been an interesting discussion point in early literature is whether there's some transaction volume discount by just buying in bulk. So we also added transaction volume in column 3 and 4 as a control variable and also adjust the fixed effect accordingly. We find some significant but very small effect of buying in bulk, in the sense that if we just double the volume, the price is only 2% lower. It cannot really explain the large benefit resulted from pooling procurement across countries. So here transaction volume is for individual transaction. And then we also look at heterogeneity by patent status and approval year. So in the first column, we have the benchmark results at panel level as a comparison. And one thing that's very interesting is that we look at country patent status and breaks the sample into ever patented and never patented drugs. We find actually there are not much difference across patent status. We do find for the patented drugs, the medicine's patent pool is very useful in reducing prices for patented drugs substantially. Across approval year, here we look at a sample by the age or the generation of drugs. So column 4 have all the drugs that have been first ever approved before 1990, and column 5 is all the 90s or in the more recent decade before our sample started. We find a very interesting monotonic difference in the magnitude of estimates. We basically find the cross-country pooling reduces prices more for older generation of drugs. So one potential reason is cross-country pooling helps reduce information friction and gathering those manufacturings for this relatively cheaper off-patent drugs, and then can make it more efficient to coordinate delivery and purchase together. We also did some other heterogeneity along the line of something people have been interested in the literature. So prior literature have mostly looking at manufacturer HHI. So here the HHI Herfindahl-Hirschman index that measures how concentrated is the market. If HHI is large, that means the market is very concentrated with very small number of players. With low HHI means the market is more competitive with a lot of sellers in the market. Prior literature look at within country pooling and find within country pooling is more useful in country in market with more competitive market. And we find on top of that international pooling is most effective when the markets are more concentrated. So basically within country pooling will not be able to give you as much advantage if you are in a market with a small number of large sellers, but cross-country pooling can help you gather the demand and have higher bargaining power when coordinating and bargaining in a market with higher concentration. In contrast, within country pooling is most effective when the market is less concentrated and when the buyers are large. So if you're a country like South Africa, then probably you don't really need to bundle and group together with other countries to be able to negotiate a good rate with sellers, simply because the internal demand is large enough to supply a good amount of good deal. Okay, and then you may say, we probably know a lot about prices, and there's no question about pooling can reduce prices despite the theoretical ambiguity, but how about non-price outcomes like delivery conditions? How long should we wait? Importantly, stock out or out of stock of essential drug is really a major problem in low and middle-income countries. Sometimes it's more relevant compared to prices, and people are willing to pay higher prices to get the drugs earlier. And we can distinguish stockout risk into different components. It can be increased by either a lengthy procurement lead time, measured by the number of days between the date of order and date of delivery, or delays, that's indicative of whether or unexpected delays, or both. So basically we measure procurement lead time and also the indicator about whether the actual delivery date was after the scheduled delivery date to capture the expected versus unexpected components. And the procurement lead time is the measure that many institutions care a lot because it's actual days you waited. And then the delay indicator gives idea about whether you actually like it or whether you anticipate it or not. Of course, we can also calculate differently with the anticipate procurement lead time, but basically the results are very consistent. So we basically test how those delivery outcomes vary by procurement institutions. What do we find? Overall, we find that although shipments are 26% to 28% less likely to be delayed with procurement institutions, the procurement lead time is actually substantially longer for those procurement institutions that takes pooling into the limit. And depending on whether we look at the panel regression result or the transaction level estimate, it's about 105 to 114 days. So that's like more than 3 months. The question is that, do you willing to wait for 3 months for lower prices? But on the same time, the interesting thing to interpret them together is that most of those delay are anticipated in a way that you have to put the order earlier and tell people that and have anticipation that, okay, I'm willing to join a pool to aggregate demand with the possibility of just waiting with the exchange of like good price, but I have to wait longer. So one question is, as we may remember from the summary statistics, for some of the observations, the lag has been really long. So you don't really want to believe that you want to order a drug that's delivered 3 years later. But in reality, some government may be planning about getting drugs in batches. So I'm going to order the same drugs for the next 3 years, but because I think the drug may have shelf time or I don't need all of them at once, so I just plan this ordering for the next 3 years and you deliver it to me one batch a year. So we also drop some pre-planned order to look at this ones that's more reasonable within a year. And in this case, we still find a fairly consistent result in the way that there's still increased lead time, although it's of a smaller magnitude when using PPM. And then one question that can be really relevant for people thinking about whether to use procurement institution or not is whether using procurement institutions actually restricts the type of drugs a country can buy. So here we collapse the data at country by year by drug category level, and we look at two particular dimensions: whether procurement institutions restrict the percentage of patented drugs a country can buy, or the percentage of old drugs. Then you can do the inference with the newer drugs. And overall, we can find there's no significant difference in the percentage of patented or older generation drugs purchased across different procurement institution types. And now it's worthwhile to think about discussion about the trade-offs and potential mechanisms. So it seems that international pooling has some advantages. Then why do not all countries use those pooling mechanisms? So one thing to keep in mind is that pooling international is good, but it's not available for all the products. For PPM, about 80% or above for ARVs, antiretrovirals, are covered. For non-ARVs, they're only about 30%. For UN, the coverage is slightly smaller, but here we also basically have a graph showing that. So although like PPM is only starting from 2009, it's gaining momentum. If you're buying antiretroviral, it can be a really good opportunity. But if you're buying some other non-ARV drugs, then your choice set will still be limited. Although it's not limited in the dimension about older drugs versus patented drugs, but you do have smaller set of choices compared to others. And then PPM also really requires advanced planning that differ by products. As elaborated before, when you're using pooled procurement mechanism, you have to keep in mind that you're reminded that you have to plan early and keep in mind that you have to wait. That's why it has lower anticipated delay, but longer procurement lead time. And the reality is actually very complicated. We find those your report from Global Fund actually give a matrix about order buy suggestion. So if you try to get a drug by 2024 April, order urgently. And this is something they have in October 2023. As you can tell, the waiting time or the recommended order by date vary a lot across different type of drugs. And this can be really complicated for procurement management. So that's another hurdle about why like maybe you have to really mix different procurement institutions. On top of that, some countries may want to develop their own domestic procurement institutions and enhance supply chain management, as supply chain security are really important, and particularly so during emergency or political disruption. And now you may also wonder, procurement institutions are not really generated as random for a good reason. Can we also provide more additional evidence about this causal effect? So basically, we try 3 different things. primarily, and a lot of other additional institutional tests. So the first concern is procurement institutions are not chosen at random, even after controlling for extensive fixed effect and observables, which is the standard of the literature. But how can we think about potential biases? If we think about drug-specific regional demand shocks, for example, due to an epidemic, that can increase prices, but can also increase participation in pooling. In contrast, we can also think about learning by doing. As more countries gaining more experience into using the procurement institutions, they may reduce price, but there may be ambiguous effect on participation in pooling. In the sense that as you get more experience, you have greater knowledge to join and work with an international pool, but you also have more incentive to develop your domestic procurement capacity so you can be more independent and not wait as long. So overall, the direction of potential bias from OLS is not really clear. And also, given that we have super extensive fixed effect, the magnitude of that is also not very clear. What we do is we use instrumental variable approach. And here, we have some update from previous drafts, and now we have one main set of instruments. We use procurement share of instrument M for other drugs by the same country C in period T as instrument for each procurement institution M. So this is like a houseman-style instrument used in industry organization, but instead of using prices, we use procurement share that's less endogenous. So why is this IV relevant? Participation in international pooling for other drugs make it easier to use the same institution for buying drug J. At the same time, if the exclusion restriction, as learning effect or demand shocks are uncorrelated across different drugs purchased by the same country, conditional on extensive drug-by-country fixed effects. For example, a drug-specific demand shock is unlikely to immediately affect procurement institution choices for other drugs. And I think there may also be correlated drug shocks across multiple related drugs. And in this case, we construct the instrument using procurement share in other drugs, in other drug classes, and we find very similar results. So here's the table with our estimates. So overall, the magnitude also looks similar to before. We find, in general, significant reduction in prices from ppm and UN. And also here, as Josh Angrist once famously said, life is hard enough with one endogenous variable. Why you want to have multiple? But we try to be thorough and say, okay, let's first have ppm as the variable to be instrumented, and then only UN, and add ppm and UN, and then we instrument all the procurement institutions. But in general, we find things really similar. And the IV is also very similar to the benchmark at transaction level that we reported in the appendix. And also the overall pattern remains similar for delay and lead time. But you may still have the question, are the key patterns driven by observed heterogeneity? Or to what extent omitted variable matter? To address this point, we use Altonji-Elder-Taber-Oster method, basically the AET method originally developed in educational economics or labor, basically tells the relationship between treatment and observed controls can provide information on the relationship between treatment and observed controls. And Oster jumps into further use the movement in R² to measure predictive power of controls, and then we can calculate the bonds. So basically compute the bonds of treatment effect beta star, and then we overall find pretty tight bond for each of the main coefficient estimates. And that's also pretty robust with different assumptions about the magnitude of selection for observables versus observables. And then you may still have a concern that are we really capturing the procurement institution stuff, or are we picking something up about demand elasticity? As demand elasticity can be different for buyers that purchase using different procurement institutions. In particular, price discriminating sellers may charge lower prices to buyers with more elastic demand. To address that, we are actually capturing supply side factor rather than capturing demand side factor here. We do regression using log quantity on log price, and also with interaction of log price with different procurement institution share. So here, the regression estimate have a nice elasticity interpretation, as alpha P gives demand elasticity when all of the drugs are procured directly from manufacturer. On top of that, alpha PM gives how the demand elasticity changes as the share of transactions by procurement mechanism M increases. And we use Houseman instruments as the prices in other markets reflect on the cost shocks and hence serve as supply shifters. As you can see in the reported results, we actually find the opposite result compared to the concern, in the sense that demands are not more elastic for cross-country pooled procurement. It's actually less elastic. So we basically sort of reinforce the idea that we are capturing some supply side factors from procurement institutions rather than demand side elasticity story. And of course, we want to understand the institutional factors more, so we have done a lot of analysis trying to figure out other institutional factors, as PEPFAR and CHAI are both very important during the sample period as large buyers and also as an institution providing selling or reference prices. There are also other management practice that can be associated with lower variability in procurement orders, or are you comparing with in-sample median prices in making your procurement choices, or what has other management-related factors like tiered pricing, advanced payment method, or drug sampling, or other things, startup effect of PPM. So in general, we did a battery of different tests and analysis, and there are more details in the draft. And we generally find something really similar to the benchmark, so we just keep the detail as additional tests. And of course, we also look at heterogeneity by drug category. We find largest price reduction from cross-country pooling for antiretroviral and tuberculosis drugs, but with limited power. We also test the complementarity of pooled procurement institution and the pooled IP licensing institution by adding an interaction term to see whether they work better together. And we do not really find any statistically significant evidence of either substitution or complement. Overall, to conclude, we find pooled procurement institutions lower drug prices and potentially reduce delay, but at the cost of longer procurement lead time. So this is plannable, but may not be ideal in all the situations. We also find pooled procurement institutions are overall effective in facilitating drug supply, especially for older generation drugs. And thankfully, there are also intellectual property licensing institutions like the Massachusetts Patent Pool that can be more useful for getting more newer generation patented drugs. So in general, we find there's no one-size-fits-all institution, and countries may consider using a mixture of institutions for various scenarios, whether it's regular or emergency. You can also find the link to my other paper about the Massachusetts Patent Pool, which is also doing a lot more work during and after COVID. So that can be also a resource for future research area. Okay, thank you. That's all I have.
Great. Thank you so much. So to our listeners, if you have any questions, please put those in the Q&A. I guess I will start us off by asking a few things. So I'm curious, have you spoken with any policymakers about these results? Are they surprised, expected? Or you plan to do so? Just curious about any of them.
Yeah, during the process, I'm really grateful that we got to talk with many practitioners, not really influencing policy, but a few interesting cases. While doing the analysis with additional buyer with CHAI, we actually talked with some procurement leader in the Clinton Foundation, and they told us, oh, everything makes sense. And actually, when we try to figure out why CHAI is playing a less role since like 2009 or after, they say like, oh, as the PPM has been doing this, so we just feel like it's better to specialize in different areas. And they actually also told us they are also like actively communicating with the Massachusetts Patent Pool and think they are doing a great job. Regarding the like lead time and prices thing, we talked with some expert in Global Fund, although we did not manage to reach the procurement team. They're actually really, really busy. But overall, they find the result makes sense, and it seems that they discuss our paper. What we find very interesting, it seems that maybe we endogenized what they put up as a report, as previously they do not have the order by matrix, And now maybe they say, seems like researchers are interested in our work. So they actually put in this information about other biometrics. We also really find this very enjoyable process to learn from practitioners. As some of the information about how does the procurement process work, when did you put in order and other stuff that we have appendix about the process, is something they actually learned from discussing with some procurement agency in Africa. A pharmacist in Ethiopia is particularly interesting. They actually reach out to us regarding the paper. So I feel like, they're actually doing more things in the perspective. Hopefully we can learn more and think about how to design it better.
Great. I see there's a question here by Shannon. Would you like to ask?
I would be.
Yeah, sure. Thanks, Karen. Hi, Lucy. It's great to hear your presentation. So I'm just curious because I don't know much about the drug production and procurement stuff in a global setting a lot. I'm just curious whether it might make sense for us to expect those countries, low and middle income countries, to have their production capacity for those set of drugs that are essential and are old generation, because I think they are generally thought of as having low production costs, and because they've been on the market for many years, probably it's not very hard to get the production technology. I don't know, what is the current situation? And if they are not doing that, what are the potential barriers?
Yes, I completely agree. And actually, one result I've got to emphasize is that the trade-off does not really exist with central medical store. In the sense that during our period, although if you use international pooling, you may have to decide whether you're willing to wait in exchange for lower prices. But if you have the centralized procurement institution within the country, then you can actually organize things more efficiently without having the trade-offs. So if a country wants to be more self-sufficient, then yes, it is definitely a good way to go. But why countries not always doing that? So another thing to also mention is that during our sample period, not every country has been using international procurement, including, let's say, South Africa never used it because they have their own centralized procurement institution within the country and has been working well. So to some extent, it's the case that for the 33 countries that never use PPM, why it's the case is maybe a combination about they don't know how to use international procurement, and we already have self-sufficient institution. So my general take is that it's always nice to learn about how to build self-sufficient institution, but the challenges for doing so are different for older versus new drugs. For older drugs, one challenge is that a lot of countries don't have the production capacity. Like China, India are in a relatively good situation that the generic drug manufacturer industry is really large, and there are more production know-hows. But in many African countries, is relatively less so, and it takes time to build this infrastructure. Another barrier for older generation drugs is maybe you lack the technology know-how or lack the high-skilled personnel to do that. For that, I think a very interesting potential future topic can be looking at the technology transfer hub that the Medicines Patent Pool has been helped putting in South Africa in particular. So the idea is that, yes, we can try to help pool intellectual property and pool procurement for some of the drugs, but then we have to focus on the drug with high return. That means we're going to prioritize infectious diseases and communicable diseases. But if a country wants to do better in non-communicable diseases in particular, then being self-sufficient is particularly good. So I think it will be really interesting to look many years after and in different settings, different countries, to see how does different institutions work better, and also how to build this internal self-sufficient system.
Yeah, great. Thank you. Any other questions from our audience? Please ask. Last few minutes here. Maybe I'll ask, Lucy, since you mentioned the pandemic experience in COVAX, is there anything related to that you wanted to share?
Yeah, that is actually really interesting because I do remember there has been a large discussion about that. And at a point I was I went to Germany for a year before returning. So I heard both the European voice and the US voice. People were super excited about pooling vaccine procurement and this idea about both pool the demand and pool the supply. but the coordination cost is so large, and because there are a lot of technology-related know-hows, not really easy to develop. So I think for those type of thing, it's really hard to do. Meanwhile, China is interesting because I do remember like my parents get vaccine earlier than I do because they're both essential healthcare workers. They get the Sinovac and Sinopharm. So those are inactive virus vaccine, but I have to wait for a very long time to get mRNA vaccine. So I do see there's also a trade-off in terms of, okay, you may want to get mRNA vaccine as ideal case, but do you rather want to wait for a certain time or get a vaccine that probably work, maybe just with slightly lower efficacy? So with the COVAX case, I think that's also a reminder about whether polling works also really depends on the technology. And I think moving forward, as also we are living in a world with biologic drugs, those can be more complicated. So the overall labor force is also very important, because one thing that I remember as particularly striking is some African countries have to return the delivered mRNA vaccine to COVAX because they don't have the facility to put them into cold chain, and they don't have the healthcare workforce, the healthcare professionals to inject people. So that was very sad, because those vaccines that are wasted can be used better in other people. So that's a lot of lesson to learn in the process.
Great. Well, finally, just to wrap things up, you already alluded to one of these. So my final question, what do you see are the open questions in this area, particularly for emerging scholars, students doing work in this area? Where would you encourage them if they want to find data, do research on procurement institutions or essential drug supply or a related topic?
Yeah, thank you so much. I definitely think it's a very exciting area, and there can be multiple different directions. So for example, centralized procurement has been a big topic, and Jianan has a wonderful paper also looking at the health outcomes there. And it's also appeared to be a trend. So China has experimental cities, but also expanded that. One question that can be interesting in the China context is that people generally agree they reduce prices and can have good health outcomes, but when try to roll it up to additional provinces, do we see some potential trade-off or hidden costs regarding investment or innovation? As I also heard from practitioners that some generic manufacturers are complaining about, yeah, we want to innovate and have self-sufficient innovation, but that also costs money and hire scientists. So I think having a nuanced look about what segment can be protected, or what has a better design to strike a balance between domestic innovation and procurement and lower price through centralized procurement can be interesting. Another particularly interesting thing, I think, in the global landscape, there are a lot of new developments through the medicines patent pool. And also with the interesting China angle is I noticed many Chinese manufacturers has been actively participating, but the geographical region that medicines patent pools requirement is that, okay, you can have no royalty rate or low royalty rate if you sell in certain country. And because China is big enough with good market, that means you may not benefit from the sales region, but just by participating early and get the know-how, firms in China can potentially introduce some of the patented drugs in China faster through another channel. So I feel like the technology spillover effect through the international channel to domestic market can be also very interesting. And then on top of that, there can be technology transfer hub in different countries. So look at how does this technology transfer hub affect innovation and international collaboration can be really interesting. And also finally, I'm very curious about the new drug patent linkage system in China, as it's basically modeled after the US Hatch-Waxman, but we don't really know how it works. So whether having a more westernized system with Chinese characteristics can incentivize more China-oriented innovation can be really interesting.
Great. Well, thank you so much. And thank you to all of you who have joined us today. No doubt join me in thanking Dr. Wang for sharing your very important research.
Thank you so much for inviting